So we're going to talk about a better way of addressing disparities in primary care research, and it's a little bit of a different take on disparities. Denise introduced me, and lots of really nice things she said about me. But really, this is a whole huge group, including Denise, who worked on all of these wonderful projects. And we did receive some funding, so I'd like to acknowledge our funders as well. Now, disparities, I had to look it up in the dictionary, so I went on Google, and it's about a great difference. And that's really what I'm going to be focusing on. It's a bit of around economic disparities between different regions of the country and differences. But I'm also going to be talking about primary care. And primary care, I'm talking about primary care in terms of Dr. Barbara Starfield's definition. And you can see that on the screen. So I am concerned about the disparities in primary care research. We know that there are huge disparities. When we look at other healthcare disciplines, there's a disproportionately low amount of funding that goes to primary care and to family physicians that are involved in research, as well as other primary care providers. There's also very few academic papers that are published by family physicians. I'm a family physician, and you can see 1 out of 1,000 papers are published as compared to other groups. So I see that as a disparity. There's been recent reappraisals, and you can see the reference at the bottom looking at the system, and we're faced by disparities in rural and sparsely populated areas, in Alberta as well as Australia and Canada. So, learning objectives. Hopefully after you hear this presentation, you'll learn and be able to describe the complexity associated with delivering prevention and screening in a primary care setting, as well as you'll know some of the barriers and facilitators to taking up evidence and research in terms of clinical practice guidelines into practice, and you'll be able to summarize some of the processes that we used in our better approach. And I have an outline, and first of all, I'm going to talk about the disparities in primary care. And you may have heard about the second valley of death, so we'll be talking a little bit about that. So how can we reduce disparities? We can do research with primary care instead of on primary care. So we need to be engaged through the entire process. So many times I have researchers coming to me, inviting me to be on their project, but it's not with me. What about the second valley of death? Have many of you heard about this? 2 valleys of death. We were looking at translation of research and evidence into practice. And it's a metaphor. So when you look at the translation of basic science into, for example, clinical practice guidelines, you see there's a big valley there of death. And then there's a second valley of death when you try to translate that into practice. Now, this is well known by our funders. And they have developed strategies to address this. And you probably know of those. For example, the NIH has developed Clinical Translation Science Awards, and that's an attempt to address this. And CIHR, we have the SPORE. All of them recommend that primary care should be a collaborator. We should be on the project working with the researchers. There's another illustration, and I think some of you know about the ecology of medical care. How many of you heard about that? Yes, and sorry, I'm going to go over it again. I think it's it's very important to comprehend that. You've all seen this, many of you. Those of you who haven't, what they looked at is 1,000 persons, and Kerr White first did this in the 1960s, and then Larry Green revisited it. And of 1,000 persons, 800 will report symptoms. Now, it goes down to 1 winding up in an academic site. So when we look at information that we're collecting data on, those persons that, wind up in an emergency department or an academic hospital. But in primary care, we're interested in a different group. And we don't really know what the problems are there. So there's a disconnect. And we need good data to be able to answer our questions. And the data sources that we have, the primary care data sources are, from those patients that visit other areas, such as billing systems, hospital data. But we have recently in Canada, the Canadian Sentinel Surveillance Network has collected point-of-care primary care data. So this is a community laboratory, in my mind, and we have trouble getting infrastructure funding for that. And why is that when that data is so important? So how much are we missing when what we look at is the Wallies and the Waldos? We really need to look at the community patients. So I've talked a bit about valleys of death and about ecology of medical care, and there's a gap in research, and there's a disparity. What about prevention and screening in primary care? And why is that important? Well, it's very important. When we look at the prevalence of chronic conditions, they are steadily rising. And they threaten our healthcare system. And WHO has identified this as the most pressing health challenge facing the world. And there are so many good guidelines about what we should be doing in practice, right? We know what we should be doing. The research is there, but it's not being translated. Why is that? I think it's because we have a disease care system. So the guidelines are focused often on a disease or an organ system. And when we have a patient come in, that patient may have 3 diseases, and they have certainly more than 1 organ, and they really look more like that. So our resources to help us address the individual patient are just not adequate. And that is where the research isn't being translated. Now, also, a family physician trying to keep up to date on all of the clinical practice guidelines. If they pick the top guidelines, there was a study done a number of years ago that demonstrated that it would take an additional 7.4 hours in a day. And I just can't stay behind that late at my practice, So patients are not getting the screening and the preventive maneuvers done. So what's the answer? We need a better approach. We did a trial and we demonstrated the effectiveness of a patient-level intervention, and I'm going to describe this briefly before moving on. This intervention involved someone called a prevention practitioner who became skilled in prevention and screening and would meet with patients, and the prevention practitioner had a toolkit, a better toolkit. That was all the high-level guidelines blended together to be tailored to the individual patient. And an intensive visit resulted in a prevention prescription. And this resulted in hard patient outcomes. So how did we do this? With the research, and there's been a number of projects, we did consider the Consolidated framework for implementation research. Now, I have published about the Better program, and I describe a number of frameworks that we did look at. And there are many. There are theoretical domains, Paris. There were many, many different types of frameworks. But we found this was good to conceptualize, and I'm going to use it to illustrate some of the things we thought about in implementing the projects. So when you look at one, that's the intervention. The intervention, the clinical practice guidelines, would not work in practice. They're disease-orientated. We needed something more patient-orientated, so we needed to blend the guidelines. So they needed to be adapted. The external stakeholders needed to be part of that. So we engaged decision makers, policymakers, researchers, the prevention practitioners to work together on developing the tools. And that was really important because in one province or one jurisdiction, we couldn't do the same screen that we could in another, and the decision maker knew about that. The tools also included links to external resources that the prevention practitioner was able to identify, resources where they could refer patients to for things they needed, such as quitting smoking. The practices that were involved were engaged through the process to help tailor the tools, also including the prevention practitioner. And where we could, we identified champions who could help move this forward in the practices. The prevention practitioners, that's the individual that would meet with patients, worked throughout the process, tested the tools, and came back to the group about what tools could be added or modified. There was a guideline harmonization process, and this Denise Campbell-Shear played an incredible role on because she led the group through a number of iterations. And I'm going to describe that briefly. I think that is one of the key things that made this work. So we worked with the Center for Effective Practice first to look at an evidence review, and we pulled all the high-level guidelines in evidence and collated them and decided what to go to the clinical working group with. The clinical working group consisted of clinicians, prevention practitioners, policymakers, and has had also patient input. And they divided into groups, tasked with either focusing on the lifestyle guidelines, diabetes, and different guidelines and resources. And this, I don't expect you to see all of this, but it shows the steps. So we had a number of meetings initially with the clinical evidence review that developed the guidelines and pulled what should be brought to the clinical working group. Then the clinical working group, each lead of the groups worked on their own, pulled out the guidelines, and then you can see here they would meet at different times as a group and decide what to include. We identified 28 actions that we thought had very high-level evidence and should be included in our outcome measures. And they are listed here in terms of the domains that we looked at. You know, things like quitting smoking, losing weight, cutting down drinking, getting your mammogram done. 28 items. This is Denise's hard work with the team on the process we used, and this has been published, and I don't expect you to see all the details. It's informed a lot by Dr. Ian Graham's work on, knowledge translation. So also the CIFR helps, but we also needed to think of knowledge translation at the sites. And how do we implement the tools? So this shows the process used. The tools, the Better Survey was one developed, and it collected information from the patient that the patients could do either orally or in person, and specific information around their risks, including family history, and if they were ready to change some of their behaviors. A lot of this was informed on behavioral science as well. This is a care map, and it just illustrates all the guidelines blended together. And this would guide the prevention practitioner who would work through the care map to determine whether certain targets were met, whether the patient needed to be referred back to their family physician, and what to do with different conditions. So this is the key blending. These bubble diagrams highlight the high-level evidence for patients 40 to 65, and they were used when meeting with the patients to help make decisions. The prevention prescription was a tool that the prevention practitioner filled in with the patient and provided the patient with details about their health. And on this, they would see where they stood. They would have all their lab values, what they were, whether they were on target or not, when they should be repeated. They would be, if they were behind on something, they would be offered a mammogram or that to get up on the screen. They also, through a process of brief action planning, which is grounded in motivational interviewing, would tailor a goal, 1 to 3, to improve their health. A number of tools have been identified, and the poverty tool is also a resource that has been developed in Canada. And using a screen, we can identify patients that are at risk for poverty, and the tool can guide an individual working through how to address this. Okay, I'm going to talk a bit about what the results of these projects were. The BETTER trial, the original trial, was a pragmatic randomized controlled clinical trial in 4 practices in Alberta and 4 practices in Ontario. We collected information on the 789 patients that participated. The specific objective is to look at if we could improve chronic disease prevention and screening as determined by a composite index in adults 40 to 65 years of age. We had 2 interventions. One was at a practice level, and one was at the individual patient level. The practice level was a practice level facilitator, and they would work with the practices looking at the electronic medical record and how to improve prevention and screening in the practice. They did have the toolkit, but often they would focus on one item, such as getting smoking captured in the EMR. The prevention practitioner, using the tools, would meet with individual patients and tailor a prevention prescription to that patient. We also considered a disparity, and that's moderate mental illness. When we looked through the literature, we found that there was little known about whether they could achieve prevention and screening goals and what would work in this group, and they are at risk. So we looked at a strata to see how moderate mental illness patients that had this condition would improve. And what we found is that with the prevention facilitator, there was a slight improvement, but it wasn't statistically significant. But with the individual patient facilitation through the prevention practitioner, it was very significant. So we saw a big difference. And what we found interesting when we looked at our mental health strata is that they also improved. So we were puzzled by this because we really thought the practice level facilitation would be the best. And we did do a qualitative study to look at what was going on here. And what we found is that prevention practitioner is actually doing practice facilitation. She or he is acting like an external practice facilitator, but is embedded in the practice. And what was so much more powerful was there was a relationship with the individual patient, but also everyone on the team, the physician and the other healthcare providers. And I had physicians coming to me that had participated in this project, and they said, I had these patients for 20 years or so, and I never knew they had a drinking problem. But they had no problem telling the prevention practitioner that. And even though the patients knew that would come back to the physician, for some reason they were able to disclose that and address the concerns. So the change, we believe, is, because of the process with the individual patient and external and internal facilitation that goes right down to the patient level, and it's key through all the relationships that are being developed. The moderate mental illness, we found the patients were eligible for prevention and screening maneuvers. They had more of those. So in that patient group, they had more goals and actions that were not met. And that although they were able to complete a significant number, they did not reach the same level as those without mental illness. So I do think we need to study this group more, and we need to be aware that when we have patients with this, they are more at risk. So the trial demonstrated that we found an effective way to improve prevention and screening, but this was in multidisciplinary team practices. What about rural? We know that rural and remote can be disadvantaged settings. So the next step was to look at how this worked in a rural remote community. And we looked at better program implementation in Newfoundland and Labrador. And Labrador was Happy Valley Goose Bay, which also had a fair number of Aboriginal patients in that practice. And what we found was a very similar result to the better trial. These patients had actually more actions to achieve, and they received a similar amount. So we found that this did work in these communities, and we were interested, again, in that, what are the barriers and facilitators in this setting? So to understand that, we did a qualitative study, and we did key informant interviews and focus groups. We also had patients fill in comments. So we used the Consolidated framework to frame our understanding of this. And as you recall, there are 5 domains. When we looked at the intervention, it is a very complex intervention. And we found that that was both a barrier and a facilitator. The patients really liked the complexity because it addressed their individual needs. And some of the healthcare providers did too. However, others found it was quite complex. We looked at cost, and we found varied ideas on that. It was perceived more a barrier by the physicians. And in Canada, we're in a fee-for-service setting. So the cost of having somebody doing this was perceived as a barrier. Even though some of the settings, they could adapt and bill for it, some of the doctors felt it could be a barrier. However, others, decision makers and others, saw it as a healthcare cost saving. Perception of fit. A lot of the patients, the managers, the PPs, and some of the other staff in the clinics thought it was a very good fit. But we did find a discrepancy with some physicians where, again, they were concerned about lack of remuneration and concerned about resources. They felt acute care trumps all, and it does in some cases. Some communities, really, the acute care was very hard to address. And others thought this was a duplication of services, because some of the physicians felt they did this already. However, when we collected information from patients, patients felt quite different than that. This shows a quote from a physician who, again, felt that they didn't really necessarily need this, and it would address more the worried well. And then patients. We had 91 patients volunteer comments out of the 154 that participated. There was not one negative comment or a comment on how to improve, other than they didn't want the program to end. They valued the visit. They felt the length of time spent was appropriate, and they liked that they were able to go in detail on their health. The availability of a local champion was really important, and it really helps facilitate projects into the site and uptake. And the prevention practitioner, we found the prevention practitioners could be a nurse, an LPN, a dietitian, or a nurse practitioner. What was key is they all worked equally well, but the ones that had a key interest in prevention and liked motivating patients, they did great. I think the biggest component was planning and organizing and working in the background on this. And as you saw, there were many meetings with people to develop and craft the tools and tailor them both to the practice and then, to the different jurisdictions. So what about now? We have a Better Wise project that is underway. It's also looking at another group. We have concerns with cancer survivors, breast, colorectal, and prostate cancer survivors. We found that cancer survivor patients, despite having numerous visits with healthcare providers, achieve fewer prevention and screening goals. And I think that's because the focus is usually on the cancer. So we're looking at evaluating this approach, and we developed a map for cancer survivorship that blends the cancer survivorship guidelines into another care map, as well as with the general prevention. And we're going to see how they do. We've also added the poverty tool into this to screen for poverty, and that'll give us some understanding of what proportion of patients have poverty, and we can study that a little more. There is another trial of Better Health that's occurring in Toronto, and that's in the Durham region, a disadvantaged group. And Dr. Lawrence Passat is looking at whether this can work in a public health type of intervention with public health nurses. So back to our learning objectives. So we talked about describing complexity associated with the delivery of prevention and screening in primary care. And I think people understand it's a bit of a disease-orientated system that we're in, and that's a problem, And the complexity is really addressing the individual patient and tailoring things to the practice setting. The barriers and facilitators include blending guidelines so that physicians can use them within their clinical practice, and changing how maybe the model of care is delivered, and we can look at different approaches. We know that the typical annual physical exam doesn't have good evidence around it, but maybe we can adapt that into something more like this. With translation and integration, was better able to disseminate research into practice and cross that big gap, the valley of death. And models helped us looking at the CIFR as well as the integrated knowledge approach. When we look at addressing disparities in primary care in our research, I think we can do better in a number of ways. We can do research with primary care as opposed to on. And we have to think about all other voices as well. A lot of times, if we don't include policymakers, we may not understand why things won't work. So I think it's good to have policy and decision makers, researchers, practice, as well as patient voices on our projects to better inform us on how we can improve the system and how we can address the questions and concerns. It is only by understanding that we can frame the question properly. The other thing that I think helps is to consider disparity in our day-to-day research. All of you have projects going. You could think about, what in your project, what group in the project is disadvantaged, and how could your project look at that? And we did that in little ways, like looking at mental health, looking at the poverty tool, looking at rural and remote. I think there are many ways that every project can consider disparities. And we have a better video. Now, we got Ava, my colleague, who I consider the brainchild of all this work, Ava Grunfeld, was invited to an audience with the Pope. And this was the Cura Foundation, and they were looking at improving and addressing chronic disease. So we crafted a video for the Pope. So you're going to see the Pope's video on better.
The prevalence of chronic diseases is steadily increasing. This leads to poor health, high healthcare costs, and premature deaths. This is a global problem, with the World Health Organization estimating that 35 million deaths are caused by chronic diseases and rising. Chronic diseases are difficult, if not impossible to cure, often requiring many medications. The most common chronic diseases include cardiovascular disease, such as hypertension, and strokes, cancer, such as breast and colon cancer, and diabetes. Smoking, lack of physical activity, alcohol, and poor diet are major contributors to the leading chronic diseases. Preventing and screening for diseases before they start have been identified as the best ways to prevent the rise in chronic diseases. However, in primary care, most family doctors lack the time, resources, and tools to prevent chronic diseases in a comprehensive way. Traditional models of healthcare focus on one disease, but to prevent chronic diseases, we need a comprehensive approach. This is where the BETTER program comes in, led by Dr. Ava Grunfeld and Dr. Donna Manca. BETTER takes a comprehensive approach by carefully combining the best available evidence to inform patients about their chronic disease risk and how to improve their overall health. BETTER has clinicians, policymakers, researchers, and patients working together to improve chronic disease prevention and screening. BETTER trains frontline health professionals to become experts in prevention. These BETTER prevention practitioners are trained to use the tools and prevention recommendations developed by BETTER. Prevention practitioners come from many backgrounds, including nurses, dietitians, pharmacists, and public health nurses. Training lasts for 2 days, with groups of an average of 12 prevention practitioners per session. BETTER addresses the root causes of chronic diseases. It is unique because of the comprehensive approach that prevention practitioners take to addressing prevention of heart disease, diabetes, cancer, as well as underlying lifestyle risk factors. BETTER creates a personalized prevention prescription. It allows the prevention practitioner to consider the person's personal medical history, family history, and lifestyle factors. The patient's personalized prevention prescription includes setting goals, action planning, linking to available resources in their locality, and, most important, combined recommendations relevant to them. The researchers involved in developing BETTER found in a randomized trial that the approach produces a 37% improvement over controls in prevention and screening for chronic diseases. It is also effective for patients with mental health concerns. Specifically, BETTER led to improvements in screening for blood pressure, cancer, alcohol consumption, smoking, and nutrition, as well as referrals for physical activity and weight monitoring. The BETTER program can save millions of dollars in healthcare costs by preventing chronic diseases.
So the project involved a huge team, and this is the initial group. I'd really like to thank all of those who had contributed, and I think we can open up for some questions at this point.
Andrea Cassels from Clinical Directors Network in New York. Have you started looking at outcomes yet in these sites?
Outcomes?
Outcomes.
So outcomes we looked at were a composite index in the patients. So we looked at whether the patients achieved chronic disease prevention and screening actions. So there were 28 on the BETTER trial. So out of the 28 outcomes, each individual patient was assessed. So it was individual patient outcomes for effectiveness that we looked at. And what we found was that 37% improvement with the prevention practitioner. We found a composite outcome was more appropriate in our kind of research and what we do in terms of implementation science, because our patients come to us with multiple risks. Some patients are smokers, some aren't. But they may be drinking too much, or maybe they don't have their blood pressure assessed. So that was how we evaluated the project.
Hi, I'm Lisa Davis from Los Angeles, Division Director of Research and Evaluation at D.D. Hirsch. I have two questions. One is kind of logistic and resource related. The other is more general. In terms of the stakeholder involvement and all the practitioners spending all the time reviewing tools and talking about, what they thought the important goals were and processes, with their busy schedules, how did you engage them and message to them what was in it for them? How did they find the time for that? And relatedly, this prevention facilitator, how was that funded? Was that a one-time thing? Was that research funding? Did that continue? That's my first question. The second question is, how did you balance the tailoring of individual processes with sort of generalizability?
So the first question, looking at how we got everyone together, is what I'm hearing, and it was a big one, so it involved a lot of finding, for the practices, for me, finding out which practices would be interested in participating, and if I could find a champion at the practice and engage them to get involved. Identifying key stakeholders. As we built, as the BETTER developed, we had members, of the team that were able to identify people as well, in terms of decision making and policy. It was difficult, I found, finding the right policy and decision makers in the various jurisdictions. And we did have more success in, for example, Newfoundland and Labrador, where the ministry has committed funds and supports to this, and they were involved right from the beginning. Bringing them together, not everybody could attend every visit, but we would communicate through emails and through telephone. So again, it's a lot more work, this kind of process. I can't tell you how much more work it is.
Right, I get that sense.
But it's meaningful.
And the prevention facilitator was funded through?
The prevention facilitator, so we had a prevention facilitator for the original trial, and we had the prevention practitioner. We had the two roles. They were both originally funded through the BETTER trial. In future sort of iterations of this, only the research aspect of their jobs are being funded. So the data collection and that's outside of the normal role, because we're trying to look at more integrating it into a workflow and changing models of care. The prevention facilitator hasn't continued on because that type of approach didn't work. And what we believe, or what I think, is that the project itself through the prevention practitioner provides prevention facilitator work, and the prevention practitioner helps implement that at the site. So it was more effective just going with that. And then you had another.
So when you tailor these processes through all of that stakeholder involvement, you have a certain amount of fit between the various settings and processes. How do you balance that with something that's generalizable, potentially?
So there were some things we could generalize on, that we knew had really good high-level evidence. For example, screening for colorectal cancer, we felt FIT was the best screen. However, in some jurisdictions in the Better Trial, the policymakers were not willing to pay for FIT because at the government, at the practice level, FOBs were being done. So within the tools, we tailored it so that in those jurisdictions, that was what we considered the positive outcome. And so what the resources and tools the sites had available to them were tailored. So there's a generalizable level of high level and then adapted a bit, if that answers that question.
So our site was one of the was one of the original sites, which the study was fun. I don't think anybody didn't like it. The tools are available publicly, is that correct?
The previous tools are. Now we've just gone through an iteration and they're brand new tools. So those are going to be posted. We're also looking at developing sort of webinars and things as well. So some things are in the process of being developed and posted.
Okay. For public use, for general use, given the fact that it's got level 1 evidence, like how do we start to think about this? Should people use the tools in absence of training? Can people who are part of a larger team have a prevention practitioner that looks after the entire team, or is it only in the office? What are your views on sort of local adaptation? How do we think about what could work?
I've been running some workshops over the years for physicians and that, and a lot of physicians will take the bubble diagrams and the tools and adapt it to their own setting, but they're not necessarily doing it in the manner in which we had. As a physician in my own practice, that tends to be how I do it, and I know it's not probably as good as having somebody in the practice that can be a resource to the practice. We are looking at, down the road, developing an institute, a training institute, where we can provide training and train the trainer model so that this can be disseminated widely, across Canada. So we are looking at ways in which it can be taken up in terms of what we know works, which is identifying an individual at the site to become a resource to that site, or a number of sites, and we're looking at how that can work. But as individual physicians, a lot of us early adopters, if you're like me, I take the tools and I play with them, but I know it's not the ideal approach.
Your preventive practitioner concept, I think, is a very elegant response to what's quite a large ranging issue. And you've talked about a little bit about the additional training. From your observation, what sort of background would you expect? Because you talked about diverse health professionals. Mm-hmm. Would you expect the person would need to be a health professional to be trained to be able to deliver this? And I just was thinking more about scalability, really, and reach, being able to bring that across. A lot of health professionals are already, involved in a lot of care. So you'd be either bringing an additional person in one way or the other.
That was a concern we had early in the Better Trial, was that bringing an additional health person into the team is not feasible. And the people that we used were not additional. They were people on the team that had some time that they could devote to this, half a day a week, depending on the number of physicians. And their skill level, we have one that's at a clerk level, but she does work in the healthcare practice. She's actually in my practice. She brings my patients in, but she has enough healthcare knowledge to do this very well. But she isn't an LPN level. She's more a clerk. Yeah. And what we found, with the study itself, that around these levels, they didn't make any difference in terms of how well they did the prevention visit. We did find that nurse practitioners, it was more difficult for them. Again, like physicians, we tend to want to treat. And what this role does is it's more about integrating and connecting and directing the patient where to go for what their needs are. But, I know for myself I'm not very good at this, because when I have a patient and they have a goal, I want to do that, and I found that a bit with our nurse practitioners. So I think it's too highly skilled individual, but they could do it. I think ideally it's somebody that has a good knowledge of the field, but not necessarily as much.
Okay, and with that in mind, the whole point of preventive healthcare, I guess, is capturing people before they're sick.
Yes.
And so have you considered moving outside of the primary care medical clinic setting to maybe like lactation consultants in a pharmacy, like having it in a more diverse area where people who may be managing their own symptoms and aren't really in a diagnosed health condition state where they might present to a doctor would still be engaging with some kind of health service?
One of the, in the Better Wise project, one of the prevention practitioners is a pharmacist. So pharmacy lends itself very nicely to this, and can provide a resource to a number of practices as well. An adaptation that is being looked at is at the public health level. Now it is through public health nurses who are meeting with patients that are in a very distressed and disadvantaged situation they don't have physicians, and applying it into that setting. We are looking at can it be modified for volunteers. I don't think we can have the same level, where you're doing cancer surveillance or survivorship care plans, because I think that does require more skill. But there may be some things in terms of the behavioral that could be informed by this approach.
Thank you.
Now, I was asked also earlier about measurement, and I talked about one measurement we did. We call it effectiveness. We did use a framework called REAIM, and when you look at programs, that's a measurement that you can do, and we did look at things like that, like proportions of people that engage and things like that. So you can look at implementation of programs and other types of measures as well.